Hi guys, today we're going to continue reading Pathoma. We are starting chapter 3, Principles of Neoplasia. Neoplasia, basic principles. Neoplasia is new tissue growth that is unregulated, irreversible, and monoclonal. These features distinguish it from hyperplasia and repair. Monoclonal means that the neoplastic cells are derived from a single mother cell. Clonality was historically determined by glucose-6-phosphate dehydrogenase enzyme isoforms. Multiple isoforms, for example, G6PD-A, G6PD-B, and G6PD-C exist. Only one isoform is inherited from each parent. In females, one isoform is randomly inactivated in each cell by lyonization. Glucose-6-phosphate dehydrogenase is present on the X chromosome. Normal ratio of active isoforms in cells of any tissue is 1:1. For example, 50% of cells have G6PD-A and 50% of cells have G6PD-B. 1:1 ratio is maintained in hyperplasia, which is polyclonal. Cells are derived from multiple cells. Only one isoform is present in neoplasia, which is monoclonal. Clonality can be determined by androgen receptor isoforms, which are also present on the X chromosome. Clonality of B lymphocytes is determined by immunoglobulin light chain phenotype. Immunoglobulin is comprised of heavy and light chains. Each B cell expresses light chain that is either kappa or lambda. Normal kappa to lambda light chain ratio is 3:1. This ratio is maintained in hyperplasia, which is polyclonal. Ratio increases to more than 6:1 or is inverted. For example, kappa to lambda ratio equals 1:3 in lymphoma, which is monoclonal. Neoplastic tumors are benign or malignant. Benign tumors remain localized and do not metastasize. Malignant tumors or cancers invade locally and have the potential to metastasize. Tumor nomenclature is based on lineage of differentiation, type of tissue produced, and whether the tumor is benign or malignant. Table 3.1 shows examples of tumor nomenclature. So we have lineage of differentiation. For our first one, we have epithelium. If it's benign, it's adenoma. If it's malignant, it's adenocarcinoma. Another example is papilloma, which is benign, and if it's malignant, papillary carcinoma. Mesenchyme, benign lipoma, malignant liposarcoma. Lymphocyte does not have any benign tumors, and malignant would be lymphoma or leukemia. Melanocyte, benign is nevus or mole, and malignant is melanoma. Epidemiology. Cancer is the second leading cause of death in both adults and children. The leading cause of death in adults are cardiovascular disease, second is cancer, and third is chronic respiratory disease. The leading cause of death in children are accidents, second is cancer, and third is congenital defects. The most common cancers by incidence in adults are breast in female and prostate in males. Second is lung, and third is colorectal. The most common cause of cancer mortality in adults are first lung, second breast or prostate, and third colorectal. Role of screening. Cancer begins as a single mutated cell. Approximately 30 divisions occur before the earliest clinical symptoms arise. Each division, doubling time, results in increased mutations. Cancers that do not produce symptoms until late in disease will have undergone additional divisions and hence additional mutations. Cancers that are detected late tend to have a poor prognosis. Screening seeks to catch dysplasia, precancerous change, before it becomes carcinoma or carcinoma before clinical symptoms arise. Efficacy of screening, however, requires a decrease in cancer-specific mortality. Common screening methods include Pap smear, which detects cervical dysplasia or CIN before it becomes carcinoma. Mammography, which detects in situ breast cancer, for example, ductal carcinoma in situ, before it invades, or invasive carcinoma before it becomes clinically palpable. Prostate-specific antigen and digital rectal exam detects prostate carcinoma before it spreads. Hemoccult test for occult blood in stool and colonoscopy detect colonic adenoma before it becomes colonic carcinoma or carcinoma before it spreads. Carcinogenesis. Basic principles. Cancer formation is initiated by damage to DNA of stem cells. The damage overcomes DNA repair mechanism but is not lethal. Carcinogens are agents that damage DNA, increasing the risk for cancer. Important carcinogens include chemicals, oncogenic viruses, and radiation. Table 3.2. We will be going over this table after we finish this page. DNA mutations eventually disrupt key regulatory systems, allowing for tumor promotion, growth, and progression, spread. Disrupted systems include proto-oncogenes, tumor suppressor genes, and regulator apoptosis. Oncogenes. Proto-oncogenes are essential for cell growth and differentiation. Mutations of proto-oncogenes form oncogenes that lead to unregulated cellular growth. Categories of oncogenes include growth factors, growth factor receptors, signal transducers, nuclear regulators, and cell cycle regulators. This will be on the next page in Table 3.3. Growth factors induce cellular growth, for example, platelet-derived growth factor B in astrocytoma. Growth factor receptors mediate signals from growth factors, for example, ERBB2 or HER2 or NEW in breast cancer. HER2 stands for the human epidermal growth factor receptor 2 that controls cell growth and repair in normal cells. And signal transducers relay receptor activation to the nucleus, for example, RAS. RAS is associated with growth factor receptors in an inactive GDP-bound state. Receptor binding causes GDP to be replaced with GTP, activating RAS. Activated RAS sends growth signals to the nucleus. RAS inactivates itself by cleaving GTP to GDP, which is augmented by GTPase activating protein. Mutated RAS inhibits the activity of GTPase activating protein. This prolongs the activated state of RAS, resulting in increased growth signals. Cell cycle regulators mediate progression through the cell cycle, for example, cyclin and cyclin-dependent kinase. Cyclins and cyclin-dependent kinases, CDKs, form a complex which phosphorylates proteins that drive the cell through the cell cycle. For example, the cyclin D and CDK4 complex phosphorylates the retinoblastoma protein, which promotes progression through the G1 or S checkpoint. Tumor suppressor genes regulate cell growth and hence decrease or suppress the risk of tumor formation. P53 and RB retinoblastoma are classical examples. P53 regulates progression of the cell cycle from this G1 to S phase. In response to DNA damage, P53 slows the cell cycle and upregulates DNA repair enzymes. If DNA repair is not possible, P53 induces apoptosis. P53 upregulates BAX, which disrupts BCL2. Cytochrome C leaks from the mitochondria, activating apoptosis. Both copies of the P53 gene must be knocked out for tumor formation. This is known as Knudsen two-hit hypothesis. Loss is seen in more than 50% of cancers. Germline mutation results in Li-Fraumeni syndrome. Second hit is somatic, characterized by propensity to develop multiple types of carcinomas and sarcomas. Retinoblastoma also regulates progression from the G1 to S phase. Retinoblastoma holds the E2F transcription factor, which is necessary for transition to the S phase. E2F is released when retinoblastoma is phosphorylated by the cyclin D cyclin-dependent kinase 4 complex. Retinoblastoma mutation results in constitutively free E2F, allowing progression through the cell cycle and uncontrolled growth of cells. Both copies of retinoblastoma gene must be knocked out for tumor formation. Knudsen two-hit hypothesis. Sporadic mutation, both hits are somatic, is characterized by unilateral retinoblastoma. Figure 1.1. Germline mutation results in familial retinoblastoma. Second hit is somatic, characterized by bilateral retinoblastoma and osteosarcoma. Regulators of apoptosis. Prevent apoptosis in normal cells, but promote apoptosis in mutated cells whose DNA cannot be repaired. For example, BCL2. BCL2 normally stabilizes the mitochondrial membrane, blocking release of cytochrome C. Disruption of BCL2 allows cytochrome C to leave the mitochondria and activate apoptosis. BCL2 is overexpressed in follicular lymphoma. T14 or 18 moves BCL2 chromosome 18 to the immunoglobulin G heavy chain locus, chromosome 14, resulting in increased BCL2. Mitochondrial membrane is further stabilized, prohibiting apoptosis. B cells that would normally undergo apoptosis during somatic hypermutation in the lymph node germinal center accumulate, leading to lymphoma. Other important features of tumor development. Telomerase is necessary for cell immortality. Normally, telomeres shorten with serial cell divisions, eventually resulting in cellular senescence. Cancers often have upregulated telomerase, which prevents telomeres. Angiogenesis, or production of new blood vessels, is necessary for tumor survival and growth. Fibroblast growth factor and VEGF, angiogenic factors, are commonly produced by tumor cells. Avoiding immune surveillance is necessary for tumor survival. Mutations often result in production of abnormal proteins which are expressed on MHC class I. CD8 positive T cells detect and destroy such mutated cells. Tumor cells can evade immune surveillance by downregulating expression of MHC class I. Immune deficiency, both primary and secondary, increases risk for cancer. Now let's go over table 3.3, important oncogenes in associated tumors. Growth factor, platelet-derived growth factor. Mechanism is overexpression, autocrine loop. Associated tumor is astrocytoma. Growth factor receptors. Epidermal growth factor receptor, ERBB2 or HER2. Mechanism is amplification. Subset of breast carcinomas. RET, neural growth factor receptor. Mechanism, point mutation, MEN2A, MEN2B, and sporadic medullary carcinoma of thyroid. KIT, stem cell growth risk factor receptor. Mechanism, point mutation, and associated tumor is gastrointestinal stromal tumor. Signal transducers, RAS gene family. Function is GTP binding protein. Mechanism, point mutation, and carcinomas, melanoma, and lymphoma are associated tumors. ABL, tyrosine kinase, T9 and 22 with BCR. These are associated with chronic myeloid leukemia and some types of acute lymphoblastic leukemia. Nuclear regulators. CYMC, transcription factor. T8 and 14 involving immunoglobulin heavy chains. Burkitt's lymphoma. NMYC, transcription factor, mechanism is amplification and associated with neuroblastoma. LMYC, transcription factor, amplification associated with lung carcinoma, small cell. Cell cycle regulators, CCND1 or cyclin D1, function cyclin, mechanism T11 and 14 involving immunoglobulin heavy chains associated with mantle cell lymphoma. CDK4 or cyclin dependent kinase, amplification associated with melanoma. Now we're going to start reading about tumor progression. Tumor invasion and spread. Accumulation of mutations eventually results in tumor invasion and spread. Epithelial tumor cells are normally attached to one another by cellular adhesion molecules like E-cadherin. Downregulation of E-cadherin leads to dissociation of attached cells. Cells attach to laminin and destroy basement membrane, collagen type 4, via collagenase. Cells attach to fibronectin in the extracellular matrix and spread locally. Entrance into vascular or lymphatic space allows for metastasis, distant spread. Routes of metastasis. We have lymphatic, hematogenous, or parenchymal. Lymphatic spread is characteristic of carcinomas. Initial spread is to regional draining lymph nodes. This is shown in figure 3.2. Carcinoma involving lymph nodes. Hematogenous spread is characteristics of sarcomas and some carcinomas. Renal cell carcinoma often invades renal vein, hepatocellular carcinoma often invades hepatic vein, follicular carcinoma of the thyroid, and choriocarcinoma are the exceptions. Other than that, all carcinomas are lymphatic spread, and all sarcomas are hematogenous spread. Seeding of body cavities is characteristic of ovarian carcinoma, which often involves the peritoneum, omental caking. This is shown in figure 3.3. Clinical characteristics. Clinical features. Benign tumors tend to be slow-growing, well-circumscribed, distinct, and mobile. Malignant tumors are usually rapid-growing, poorly circumscribed, infiltrative, and fixed to surrounding tissue and local structures. Biopsy or excision is generally required before a tumor can be classified as benign or malignant with certainty. Some benign tumors can grow in a malignant-like fashion, and some malignant tumors can grow in a benign-like fashion. Histologic features. Benign tumors are usually well differentiated. This is shown in figure 3.4. Well differentiated follicular adenoma of thyroid, and this is a poorly differentiated anaplastic carcinoma of the thyroid. You can see the difference of how this image is more clear and well differentiated, and this one is poorly differentiated. Characteristics include organized growth, uniform nuclei, low nuclear to cytoplasmic ratio, minimal mitotic activity, lack of invasion of basement membrane or local tissue, no metastatic potential. Malignant tumors are classically poorly differentiated. Characteristics include disorganized growth or loss of polarity, nuclear pleomorphism and hyperchromasia, high nuclear to cytoplasmic ratio, high mitotic activity with atypical mitosis, and invasion through basement membrane or into local tissue. Metastatic potential is the hallmark of malignancy. Benign tumors never metastasize. Immunohistochemistry is used to characterize tumors that are difficult to classify on histology. This is shown in figure 3.5. immunohistochemical stain for keratin marking epithelial cells in brown. And they also have a table here with common immunohistochemical stains and target cell types. Immunohistochemical stain intermediate filaments, we first have keratin, tissue type epithelium, vimentin, mesenchyme, desmin, tissue type muscle, GFAP or glial fibrillary acidic protein, tissue type neuroglia, neurofilament, neurons. In others, we have PSA or prostate specific antigen, tissue type prostatic epithelium, ER or estrogen receptor, tissue type breast epithelium, thyroglobulin, thyroid follicular cells, chromogranin, neuroendocrine cells, for example, small cell carcinoma of lung and carcinoid tumors, S100, tissue type melanoma, schwannoma, and Langerhans cells, histiocytosis. Serum tumor markers. Protein released by tumor into serum, for example, prostate-specific antigen. Useful for screening, monitoring response to treatment, and monitoring recurrence. Elevated levels require tissue biopsy for diagnosis of carcinoma, for example, biopsy of prostate with elevated PSA. Grading of cancer. Microscopic assessment of differentiation, i.e., how much a cancer resembles the tissue in which it grows. Takes into account architectural and nuclear features. Well-differentiated low-grade resembles normal parent tissue. Poorly differentiated high-grade does not resemble parent tissue. Important for determining prognosis, well-differentiated cancers have better prognosis than the poorly differentiated cancers. Staging of cancer. Assessment of size and spread of a cancer. Key prognostic factor, more important than grade. Determined after final surgical resection of the tumor. Utilizes TNM stage system. T stands for tumor, size and or depth of invasion. N stands for lymph nodes, spread to regional lymph nodes, second most important prognostic factor. M, metastasis, single most important prognostic factor. Okay, and we have to just go over our one table that we left behind. Table 3.2, important carcinogens and associated cancers. Carcinogenic agent chemicals. First is aflatoxin. Associated cancer is hepatocellular carcinoma, and this is derived from aspergillus, which can contaminate stored rice and grains. Alkylating agents. Associated cancer is leukemia, lymphoma, side effect of chemotherapy. Alcohol. Associated cancer is squamous cell carcinoma of oropharynx and upper esophagus and hepatocellular carcinoma. Arsenic. Associated cancer is squamous cell carcinoma of skin, lung cancer, and angiosarcoma of liver. Arsenic is present in cigarette smoking. Asbestos, lung carcinoma, and mesothelioma. Exposure to asbestos is more likely to lead to lung cancer than mesothelioma. Cigarette smoke, carcinoma of oropharynx, esophagus, lung, kidney, bladder, and pancreas. Most common carcinogen worldwide. Polycyclic hydrocarbons are particularly carcinogenic. Next, we have nitrosamines, which is associated with stomach carcinoma found in smoked foods, responsible for high rate of stomach carcinoma in Japan. Nephthylamine is associated with urothelial carcinoma of bladder derived from cigarette smoke. Vinyl chloride associated with angiosarcoma of liver. This is from occupational exposure used to make polyvinyl chloride or PVC for use in pipes. And last, we have nickel, chromium, beryllium, or silica in chemicals, and it's associated with lung carcinoma. This is also from occupational exposure. Next, we have oncogenic viruses. Epstein-Barr virus. Associated cancer is nasopharyngeal carcinoma, Burkitt lymphoma, and CNS lymphoma in AIDS. Human herpes virus 8 is associated with Kaposi sarcoma. Hepatitis B virus and C virus is associated with hepatocellular carcinoma. Human T lymphotrophic virus 1 is associated with adult T cell leukemia or lymphoma. High-risk human papillomavirus, for example, subtypes 16, 18, 31, and 33 are associated with squamous cell carcinoma of vulva, vagina, anus, and cervix. Adenocarcinoma of cervix. Next, we have radiation and carcinogenic agents. We have ionizing, non-ionizing, ionizing from nuclear reactor accidents and radiotherapy. Associated cancer is acute myeloid leukemia, chronic myeloid leukemia, and papillary carcinoma of the thyroid, and these generate hydroxyl-free radicals. Non-ionizing, most common source is ultraviolet B sunlight, is associated with basal cell carcinoma, squamous cell carcinoma, and melanoma of the skin. Results in formation of pyrimidine dimers in DNA, which are normally excised by restriction endonuclease. And that was all for Principles of Neoplasia, Chapter 3 of Pathoma. If you like this video, give it a thumbs up and share to all of your friends that are trying to take the USMLE Step 1 or 2. Thank you.